others, they will convert it eventually into a chronic disease. What is that it means for us cardiologists? What it means is that the patients are going to have enough survival to develop the cardiovascular complications of cancer therapy. Just to give you a flavor, and I'm gonna use a lot the example of the breast cancer patient. You know what breast cancer patients die from? Huh? Exactly, they do not die from breast cancer. They die from heart failure as a consequence of the treatments that they got. For me, I had a little bit of a hard time, understanding that concept. And as Stephanie has mentioned, I have devoted a lot of my clinical and research time trying to kind of get on the way of that happening, trying to develop the science that will prevent us from having that. I tell you this, many times we see patients and I feel embarrassed when I see patients that are on the LVAD list or the heart transplant leads because of treatment of anthracyclines, for instance. Okay, so let's get into the talk. If you guys are interested, actually in 2018, along with my European colleagues, we actually put this review. This is emphasizing the imaging aspects because this is what I'm gonna have time to discuss with you guys. And what we discuss in this manuscript is that there are really 4 points where we participate in the care of these patients. Number 1, risk stratification. Number 2, early detection of injury. Number 3, prediction of recovery. And number 4, detection of injury in the survivor. There are, in general terms, 5 types of conditions that we evaluate using imaging: LV dysfunction, pericardial disease, coronary artery disease, pulmonary hypertension, and orthopathy. And there are 4 images or 4 tools that we use in our ammunition from the imaging standpoint: echo, nuclear, cardiac CT, and CMR. So let me tell you what I'm gonna do today. Today I'm gonna have time to talk about risk stratification, early detection of injury, and detection of injury in the survivor, and I'm gonna emphasize the LV dysfunction only. This is what I will have time to cover with you guys today. Now, if you are curious, in this publication, we include all of the toxicities. Stephanie mentioned there are new medications. I'm only gonna mention briefly one of them, which is the checkpoint inhibitors. You guys have probably heard. This is what actually gave Dr. Allison next door the Nobel Prize in Medicine for the discovery of really treatments, that are phenomenal, like what we do right now with these type of medications for melanoma. Melanoma used to be a disease that will kill you within months. Right now, you see President Carter, he was diagnosed almost 6 years ago, and he is doing great after having received these medications. So, if there is a document that is very practical, is a document that was put by ASCO. I definitely recommend that you take a look at that if you're gonna participate in the care of these patients. And they're very practical in the approach. What they do is they say, listen, what are the things that we need to know about these patients? Number 1, which one is the patient that is at risk? What are the preventative strategies that we can use before or during? And what is the surveillance that we can use during and after? So let's talk about risk stratification. So this is an important article, and you're gonna see why, because it helps us understand who is the patient at risk when you see them prior to the administration of the therapy. There are 2 important messages from the information that is presented over here. Number 1, the fact that when you get all, your risk goes up. You see over here what happens with your hazard ratio when you compare somebody that is younger than 50 versus in the 50s versus getting chemotherapy in the 60s. And very important, the other important message is which one is your baseline ejection fraction, either at baseline or after you have received anthracyclines. Just as an example, please pay attention to what happens if you start anthracyclines with an ejection fraction that is more than 65. You multiply your hazard ratio by a factor of 3 when you receive it having an ejection fraction between 50 to 64, and take a look when you receive it in what we call the near normal of 50 to 54. Pretty much the hazard ratio has been multiplied by a factor of 12. This is so simple, but it's so simple and so effective at the same time. because actually they propose a mathematical calculation where all what you have to do is you plug in the age of the patient and you plug in the baseline ejection fraction, and it will calculate the risk for you. Let me just show you a couple of examples. So this is somebody, patient number 1 over here, patient number A, is somebody that is 45 years of age and that has an ejection fraction of 65. The risk of having symptomatic heart failure of death is about 2%. Let's take somebody that is 65 years old with an ejection fraction of 55, the risk will be 12, almost 6 times higher. And this is just because the ejection fraction is lower and the age is higher. This information was actually corroborated by one of my long life collaborators, Marielle Cheddar-Crosby, who is right now the head of the Echo Lab at UPenn. And again, very simple, but very practical. And take a look over here. This is MACE-free survival this is survival from either symptomatic heart failure or death. And it tells you what happens when you start with an ejection fraction that is below the lower limit of normal, which is 53, as you know. This is if you are between 53 and 58, and this is if you are at 63. So it makes a difference which one is your baseline ejection fraction, as simple as that. I don't know if you guys have heard, there is a new imaging of modality that we are using. It's called global longitudinal strain. Probably you're gonna see it populating the echo reports, especially after January 1st, because right now we're actually being paid to do that. There is a CPT code. But again, take a look over here what happens. And usually, just for reference, what is normal is to have a value minus 19 or more negative than that. Take a look over here in this study that patients that do not have symptomatic heart failure or death have a global longitudinal strain of minus 19.7, and the ones that get in trouble have a global longitudinal strain of minus 15 or so. So much that actually you can create Kaplan-Meier curves, and if you use the cutoff of minus 17.5, you could separate the ones that are gonna develop symptomatic heart failure or die versus the ones that will not. What is interesting is that global longitudinal strain will have added value on top of ejection fraction as shown over here in this graph. So it gives you information that we didn't have with ejection fraction. I promised you that I was gonna mention the slides that you need to remember. This is one of them, okay? So who are the patients that need to be referred to your clinic? Because you're gonna go to the oncologist and the oncologist is gonna tell you, oh, so you wanna create a cardio-oncology center? Excellent. But let me remind you that 1 out of every 7 women in the United States have breast cancer. So you want all of these patients in your clinic? The answer is no way. We cannot see them all, right? So the question is which ones are the ones that need to be seen in our clinics? So let me tell you. Patients that have a dose of more than 250 milligrams per meter square of doxorubicin, or patients that receive more than 30 gray of radiation, or patients that get both. This one is interesting because historically, and Stephanie was reminding you of my times at MD Anderson, when I was there, people used to have the idea that if you will get less than 250 milligrams per meter square, you will be getting the so-called safe dose, the one where nothing will happen to you. Not the case. Right now, what we know is that you can be getting this safe dose, but if you, and right now you know where this information is coming from, if you are old, right, you have an age more than 60 years old, if you start with a marginal ejection fraction, I show you the data, or if you have risk factors, you have hypertension, smoking, diabetes, dyslipidemia, obesity, valvular heart disease, you have a high likelihood, a high chance of getting in trouble, even when you get these very small doses of anthracyclines. So in summary, you need to bring this slide to your oncologist. You need to say, listen, a lot of these patients will do fine, will never get in trouble, but patients that fulfill this criteria are patients that will benefit from being referred and from being evaluated with the imaging modalities that I am about to share with you. So let's talk about early detection of injury And this is not complicated at all. If you take a look at the ACC-AHA classification, it's pretty simple as far as cardio-oncology goes, because it tells you that every patient that is receiving chemotherapy is already a stage A. Now, what do we do with a stage A? Nothing. We just watch them, right? The ACC-AHA does not give us authorization to start beta blockers or ACE inhibitors. When can we do that? Well, we can do that if we can move them from a stage A to a stage B. How do we do that? They tell us that if we demonstrate LV remodeling, or if you have a reduction in ejection fraction, or if we have valvular heart disease or anemia, then we have the authority to do that. So the $1 million question is, when is that with imaging, I am going to pull the trigger? If I'm going to use ejection fraction to pull the trigger and to move the patients from a stage A to a stage B, I need to be using the correct modality, right? Because otherwise I am going to deprive patients from the correct therapy. So which one is the modality that we have been using up until now? We have been using 2D echo. So let me share with you how good that is in the cancer patient. This is a publication that came in 2010, and this is comparing it against what we consider the gold standard, which is CMR. So take a look over here. This is 2D echo versus CMR. Take a look at the R value, 0.31. It's terrible, right? Take a look over here at the blunt Altman, you know. So this is the mistake that we made, you know. Take a look. I mean, it can be up to 20 points of ejection fraction. Is this what we want if we are going to be using ejection fraction as the trigger to move the patient from a stage A to a stage B? Not really. The other thing that is important, because you maybe wonder, but what is the big deal about moving the patients from a stage A to a stage B? There is a lot of work by an Italian cardiologist, her name is Daniela Cardinali, that remind us that just like in interventional cardiology, time is muscle, the same principle applies to cardio-oncology. What she tells us is that initially when you start having the toxicity of anthracyclines, you have about 6 months of a chance to be able to initiate therapy so that you can be successful. She tells us that the risk of success, if you initiate that in moment number 0, is about 60%, and it goes down by 10% every month. So you do the math by month number 6, and if you have not recognized the toxicity, then the chance of recovery of these patients is 0%. So this is the reason why this is important. Now let's take a look at 3D echo, much better, as you can see, an R value of 0.91, and when you take a look at the blunt Altman, the rate of mistake is about 5 points of ejection fraction. The second piece of information is this one. We did this work when I was at Cleveland Clinic, and the question that we asked ourselves was a simple one. What is the inherent variability of echo? If you take somebody that by global longitudinal strain, there is no change whatsoever in myocardial contractility, but like in these patients, you repeat the echo 8 times in a row, what is just the variability out of the mistake that the technique will incur, that we will incur by using the technique? So it's very interesting. What we end up finding out is that with 2D echo, we can only identify differences of more than 10 points of ejection fraction. It gets much better with 3D echo, as you can see, when we can recognize, and this is congruent with the information that I shared with you, differences of about 5 points of ejection fraction. We did this publication actually working with the group of St. Jude's in Memphis. Probably you have seen the campaign in every store in the United States. They have the St. Jude's cohort survivor, and I'm going to go back to that when we talk about the third part, identification of injury in the survivor. And we compare, and in this case, it was very practical, because what we tried to figure out is how good we are for the adjudication of a stage B, identifying an ejection fraction of less than 50%. So you see over here, 25% sensitivity with the biplane method, very specific. It gets much better with 3D echo, 53 and 86%. But the most important one is this one, is over here, you have the patients that by a MRI will have an ejection fraction less than 50, but echo is saying that it's more than 50. Over here, from these 100 patients that we studied, 12% were wrongly classified, were misclassified over here. So those are patients that have a stage B heart failure that will be randomized to what I call the placebo arm, right? They're not gonna get any therapy that they actually need. And over here, you have with 3D echo, you actually cut it in half, going from 12 to 6. So this is the second slide that is important. And the message that you need to take home is that if you are going to evaluate these patients, and if adjudicating a stage B heart failure is so important, you need to use a technique that will allow you to do that. And 3D echo is the correct one. We have done a lot of work trying a different technique, global longitudinal strain. I don't know how much you have heard about it. Let me just say a couple of things about it. In this particular studies that I'm about to share with you, we went with two different approaches. One, where we use an arbitrary cutoff, similar to what I showed you with the minus 17.5, and then a second strategy where we say, wouldn't it be more practical if we look for a percentage reduction when compared to baseline, especially being mindful that a lot of these patients are actually completely normal at the beginning. So let me just summarize the findings for the study number one. Our ability at 6 months to recognize patients that were going at 12 months to have a reduction in ejection fraction were as follows: sensitivity of 74, specificity of 73%. At the same time, and if you take a look at the mechanism, why is that the ejection fraction is falling down? Because the chemotherapy is actually killing the muscle. So if you measure the troponins should be elevated, right? So we measured them, and in this case, it was 48% and 73%. And then we ask ourselves, hey, what if we use both, right? So if you have a patient that is sent to you, and the strain is normal, and the troponins are negative, then you see over here that you will have a negative predictive value of 91%. So 91% certainty that if both are negative, nothing is happening to that particular patient. This is the one where we use the percentage reduction, and this is actually what ended up going in the guideline that we wrote on behalf of the American Society of Echo. And the numbers that work are these ones, and this is coming from the guideline. So if you have a reduction of more than 15%, then you will be recognizing evidence of subclinical LV dysfunction. If it's less than 8%, then you don't have any evidence that that patient is having any trouble. This is the way that we calculate it. So this is the bull's eye for a patient that it was completely normal at the beginning, minus 25.5. I told you that the more negative, the better. So normal is about minus 18, so minus 25.5 is like super duper normal. And this is what happened during treatment with trastuzumab, went to minus 19. So if you do the math, that would be a 25% reduction. So this is somebody that is not liking the therapy and that is getting into trouble. This is a meta-analysis that was done at the University of Toronto by one of our former trainees from the clinic. There are 9 publications checking this arbitrary cutoff strategy, and you see over here the odds ratio of developing cancer therapeutic related cardiac dysfunction is 12. So they verify our initial work, and there are 21 studies looking for the percentage reduction, and you see over here the odds ratio of 15. So everybody in different parts of the world have verified this idea of either using an arbitrary or a percentage reduction in global longitudinal strain. Now, again, the question is, okay, so the strain is abnormal, and what can you do with that? So the idea would be to use global longitudinal strain as a way to move patients from a stage A to a stage B. Is there any data that this works? Well, we did a pilot project when I was at the clinic where we compare patients that after they had the reduction in a strain, we put them on beta blockers. So over here, it's in this site, and you see what happens with the ejection fraction. It gets better, and you see over here that the p-value is statistically significant, and these are the patients that did not get beta blocker. The ejection fraction kind of continues to go down, and obviously the two values are not statistically significant from each other. Now, are we, based on 52 patients, going to decide that a strain is good enough to move patients to stage B? The answer is no. So then Dr. Marwick, who was my boss at Cleveland Clinic, then created this trial. It's called the support trial. The recruitment is already final. And what they did is they randomized patients to these two strategies. Strategy number one, where we will continue to use ejection fraction as a way to adjudicate the stage B heart failure. And then a second strategy where we were going to test the global longitudinal strain pathway and figure out if the outcomes are better. So more to come of that. I mentioned, and Stephanie also mentioned to you, that there are new kids on the playground. Checkpoint inhibitors are really the biggest thing. Fantastic medications. The problem is that there is cardiovascular toxicity associated with it. It comes in the form of fulminant myocarditis. And the problem is that from the imaging standpoint, we're kind of struggling because we don't know how to identify them. You guys have seen myocarditis cases in your clinical practice. When we see them, most of the times the ejection fraction is abnormal. It so happens that in these patients that have a very morbid and in many cases fatal course, 55% of the times the ejection fraction is normal when they present. So the question is, what kind of tool can we use? And this is an abstract that was presented in ACC, where you can see that this is in all comers. This is in reduced ejection fraction. This is in preserved ejection fraction. And over here, you can see that even the ejection fraction is preserved. The global longitudinal strain will be able to sort out the patients that will end up mortality versus the ones that will not. So I think that more to come. I think that it may be that global longitudinal strain will be a helpful tool in kind of sorting out these patients, especially because, as I mentioned to you, with ejection fraction, they're going to be normal. There are other modalities that we are using, and this is some work that we have done with my colleagues in Bristol, in the UK, using parametric imaging. Probably you guys have heard a little bit of the hype about this. This is T1 and T2 mapping. So how can we use it? So in this particular case, this is somebody, and this is actually from the publication. So if you're interested, you can go and read some more about it. So this is a patient on trastuzumab. The ejection fraction when the patient got in trouble was 47%. You see over here that the T1 mapping count was elevated. This is abnormal. And the global longitudinal strain, as you can see, was abnormal, -14. I told you again, reference is about -18. This patient got better. The ejection fraction is 60%. The global longitudinal strain went up, and the T1 mapping value went down. This is somebody that we kind of help them with a little bit of medication, and this is somebody that will not need to be on lifelong beta blockers or ACE inhibitors. On the contrary, the patient at the bottom is somebody that received anthracyclines. The ejection fraction is 40%. The global longitudinal strain is -12. And you see over here with evidence of late gadolinium enhancement, presence of fibrosis, which tells you that this is somebody that will stay like this, and this is somebody that will require beta blockers and ACE inhibitors for life. Let me just wrap up to share with you a little bit of the work that we have done in the survivors. So this is work from the St. Jude Lifetime Cohort Study, biggest cohort of survivors ever in the world. And it's very interesting because if you take a look by ejection fraction, only 5.8% of the patients will be called abnormal. But if you use new technology, like global longitudinal strain or even the assessment of diastology, you will realize that almost a third of these patients are abnormal. What is interesting is that the patients that have normal ejection fraction, 1 out of every 3 will have either an abnormality of global longitudinal strain or diastology. Now, you may be wondering, and do I care? I mean, is it really important to demonstrate these abnormalities in global longitudinal strain and in diastology? Well, the answer is yes, because number one, it correlates with the dose of anthracyclines that the patients receive. It correlates with the dose of radiation that the patients receive. I will show you in a second the data on exercise intolerance and VO2 max. But more important, it also correlates with the presence of additional comorbidities that the patients have. Survivors with the metabolic syndrome were twice as likely to have abnormal global longitudinal strain and abnormal diastolic dysfunction versus patients that did not have it. So it not only tells you about the initial damage, the initial hit that they had with the anthracyclines and the radiation, but it also tells you about the presence of comorbidities. Let me just finish up with this publication. This came about 6 months ago in JCO. This is again with the partnership that we have with the group at St. Jude's. And a lot of the question right now is how is the survival of these patients once they have survived cancer? So it's pretty interesting to find out, as you can see over here, that 63% of these patients actually have exercise intolerance. This is versus 26% in the general population. And we try to figure out what are the causes of that. So we were able to identify a few of them. We were able to identify that global longitudinal strain was a predictor of exercise intolerance. Chronotropic incompetence was a predictor, and FEV1 less than 80 was a predictor. Quadriceps strength was a predictor, but there's only one parameter that was useless in the characterization of exercise intolerance and this patient. You already know it, ejection fraction. Ejection fraction was not helpful. Now, is it important to identify exercise intolerance in these patients? The answer is yes, because it really impacts the quality of life of these patients. But as you can see over here, patients that have exercise intolerance have a hazard ratio in terms of mortality of almost 4. So this is important. I mean, right now, I think that this technology will help us understand something that is very complex, which is the physiology of exercise, you know, a physiology that we have not been able to understand really well with the use of traditional imaging modalities. So just as a conclusion, I think that I was able to share with you what cardio-oncology is, what are the moments where we participate in the care of these patients, you know, risk stratification, early identification of toxicity, and identification of LV dysfunction in the survivor. And I hope that I have convinced you that there is armamentarium that is already available in your echo lab, like 3D echo, that will be better than what we have used traditional for the reasons that I explained to you. And there's a lot of interest in new modalities like global longitudinal strain. And I think that in the moment that we can demonstrate that we can use this modality to guide therapy, I think that they are going to become part of our day-to-day operation, especially right now that we're going to be compensated for that. So thank you so much. I will be happy to entertain any questions.